Welcome to the latest in our virtual Women's Rights in Healthcare series. This webinar is going to focus on the rights of LGBT plus women in healthcare, and is in particular, we've put this on for LGBT Women's Health Week, which is this week. My name's Philippa Wheeler, my pronouns are she, her, and I'm a trainee solicitor in Leigh Medical Negligence Department and a member of Leigh LGBT plus and Allies Committee. Leigh are proud champions of LGBT plus rights and were recognised by Stonewall as being amongst the top 100 employers in the country for LGBT inclusion, and we received special recognition as one of the top trans employers. Much of Leigh work involves representing those who've been injured, discriminated against, or have faced human rights violations. Many of our departments at Leigh act for LGBT plus clients seeking assistance relating to discrimination, human rights breaches and other injustices they've suffered due to their sexual orientation or gender identity. And I'd now like to introduce you to Baroness Liz Barker, who's our chair this afternoon. Baroness Barker is a Liberal Democrat life peer who sat under this title in the House of Lords since the 11th of October 1999. She currently undertakes the role of the Liberal Democrat Lords spokesperson in the voluntary sector, and in addition, she is deputy chairman of the committees. I'm really looking forward to this event, so I'm going to hand over to you, Baroness Barker.
Thank you very much, and thank you for that introduction. I should perhaps simply say that of all of us on the call, I am officially a lady, but I know my station. It's all right. Title of my introduction, I think, is going to be LGBT people and the NHS, always chasing rainbows. Because I have spent the last 15 years watching voluntary organisations such as Stonewall and the LGBT Foundation and others churning out loads and loads of wonderful documents, reports such as Beyond Babies and Breast Cancer, Pride in Practice, Opening Doors London, Pride in Care, and largely being ignored by the providers of formal healthcare provision. And what I want to do today is for us to explore why that happens and to stop it happening. You see, every year I go along to Pride and they're all there. The GMC, the BMA, everybody out on Pride. And I stand there and I think, and the other 364 days of the year, what is happening? And I think that what is happening is because of the wonderful frontline staff and the rainbow badge thing that they've started to do, things are, in terms of general one-to-one interactions in the NHS, are getting really good. But at the heart of the NHS, at the leadership level in the NHS, not so good. The 5-year forward plan for the NHS didn't mention us at all. Came to the long-term plan for the NHS, we made it into the glossary, but not into the actual test. We were there in the list of initials, but there was nothing in there. 3 years ago, the BMA produced a massive document about women's health, so big that Woman's Hour on the BBC devoted 3 entire programmes to it. Not a mention, not once, nothing. And it goes on. The NHS People Plan for 2021. Now, the NHS People Plan, really important document, full of fantastic stuff, really important about the need to look after all staff, BAME staff, understanding what's happening with the COVID crisis, disabilities and all of that. And then we get one paragraph in a 54-page document, and this is it. Other staff groups also face significant challenges. For example, we know that a large number of staff who identify as LGBTQ+ do not feel confident enough to report their sexual orientation or gender expression on their employment record. And we know the weathering effect that microaggressions have on our people. That's it. One paragraph in 54 pages. So the problem, and the fundamental problem that we have, is about invisibility and about lack of leadership. And what we know is that if you are not counted in the NHS, you don't count. So today, part of the challenge for all of our speakers is to explain to us and to help us as a community to get our way past this great invisibility cloak that is there around us in the NHS. And I'm going to be really interested to see how all of our panelists in their different ways address that issue. We're going to go first to Dr. Sue Mann. Dr. Mann is at the Hobbiton, where she is a medical expert in reproductive health, and she as such is a consultant in women's health. Interesting, you're in East London, and one of the little projects that I work with is the East London Out project, and they have got some really fascinating insight and detail about the sex and reproductive health needs of particularly of younger lesbians and bi women. So Sue, over to you. What do you think are the challenges and how are we going to get through it?
Yeah, so thank you so much, and thanks for inviting me to this event. And I'm going to take up your challenge and actually put my hand up and say we are not getting this right. I absolutely would agree, both from my frontline experience, but I'm also medical expert in reproductive health at Public Health England, and so trying to bring these two parts of my life together and really seeing that there is a gap here. So I'd be really interested to hear what discussions we're going to have going forward about what. So I've been asked to talk a little bit about sexual health and reproductive health, and my expertise is more in reproductive health, but I wanted to start off by saying actually we know, and largely we know from research, because I think as Baroness Barker's alluded to, often these things are not well presented and well counted in routine statistics. So whilst I think a lot of the sexual health statistics have got better in terms of collecting data around gender identity and sexual orientation, we don't actually routinely produce reports about what sexual health looks like. However, we do know that lesbian and bisexual women report a higher incidence of ever having had a sexually transmitted infections compared with heterosexual women. And I think that's a really marked finding. And we also know that young bisexual women have poorer sexual health on the whole. So they tend to have more partners, earlier sex, and more unintended pregnancies. And I think a lot of these needs are getting missed. And there is a problem with access, and access is a kind of broad word, I think, because access isn't just about people trying to get into services, it's about how they're managed when they get into services. So if we think about cervical screening, for example, uptake of cervical screening is poor across the board, and we know that it's kind of less than 80%, it's probably somewhere around 75% of the population. However, in lesbian and bisexual women, it's less than 50%. And we have to ask ourselves why this problem is there. And a third report difficulties in accessing services. And some of that is around the information that we provide to women, but actually it's also about the receipt they get when they come into services. And I think there's a real lack of knowledge amongst professionals. I think there's a lot of assumption that goes on about being heterosexual, needing contraception. I know in my own service that often these routine questions will be asked, and without really thinking about actually the person in front of you. So I think I would put my hand up and say we don't always get that right. And that's something that we really need to address in terms of educating health professionals, and also worse than that, about some of the negative reactions that people receive when they do come into services. So I think that there's a whole raft of issues that need to be addressed across the whole pathway. So yes, of course, let's get information out to people, information about health needs and how to access services, but also let's educate the professionals within the service to provide a good, equitable and supportive service. And let's get the reporting of the outcomes right so that we actually know what the problem is to start with. And I wanted to kind of sort of finish really my introductory talk by flagging there's two really important bits of work that are coming up. We have the Sexual Health, Reproductive Health and HIV strategy, And we also have a women's health strategy, and you will have seen that there's been a call for evidence that has come out earlier this week on International Women's Day. And I think these strategic pieces of work represent an opportunity, and I think that, you know, let's get it on the national agenda. And so I suppose I'm kind of here to listen to what people say and to try and support getting something in those strategies. I think that the strategies purport to have a focus on inequalities and putting the building blocks in place so we get the leadership right, so that those people on the front line are actually delivering care at the point of access in a positive way. So I'm going to stop there because I'm interested to hear what everybody else has got to say, and hand over to the next speaker.
Thank you, Sue. Some really important points there about education, but also about until this is, you know, until the NHS is ashamed of putting out documents that don't mention us, what hope have we got of getting ourselves into the agenda? Would you know, for health training or whatever. I want to encourage people to be putting their questions into the Q&A. Delighted, I can't tell you how delighted I am to see Dr. Nikki Kanani from the NHS England, Medical Director for Primary Care. Nikki, I don't know how much you heard about this, but we are talking about the complete invisibility of lesbians in the NHS, our total absence from many of the strategic documents that govern the NHS and its work programmes, and we are talking about how we can change that to improve the health outcomes that we know our community deserves. Over to you, 5 minutes, go.
Thank you so much. First of all, thank you for having me, Baroness Barker. That even as you were just talking in the last sort of 30 seconds, I feel a real sense of not just privilege to be here, but I want us to learn from events like this so that we can make sure that we are really committed to making visible what has previously been invisible. And we have a way to go. But if I do just take a few minutes, and then really happy to take questions. So I'm Nikki, I'm a GP, and I'm Medical Director for Primary Care at NHS England and NHS Improvement. And I don't think you'll mind me saying I'm also working, well, really focusing on the vaccination programme at the moment. And one of the things that both COVID and the COVID vaccination programme have exposed are real, are the health inequalities that we've known exist, but have been much more palpable because of both the pandemic, and we need to right that. And one of the ways we can right that is by offering and having really good uptake in the vaccine programme so that we protect you. So please, when it's your turn to have the vaccine, take up the vaccine. And if you have questions or queries, Michael, myself, others are really happy. You know, so if we want to have a session on that at some point, please let me know, because I'm really keen to support. So let's talk a little bit about primary care, my day job, or my real other job outside of the vaccination world. And there's probably a few things that I'd like to focus on. First of all is the GP patient survey. This is the first time that we've really been able to use the GP patient survey in a much more powerful way. So in 2020, approximately 700,000 people responded to the GP patient survey, with 21,000 LGBT patients or patients who selected other for the sexual orientation question. So broadly, 9,000 gay or lesbian patients, 6,000 bisexual patients, and 6,000 patients who selected other. So that gave us a wealth of information at a scale we've not had before, and that's always improving. But that is key to driving how we design and deliver services. And what we found was not going to be a surprise to many of you, but let me just run through that. Lesbian, gay or bisexual patients were more likely to report a long-term condition, disability, frailty or illness. And in general, bisexual women reported worse experience in general health when compared to lesbian women and heterosexual women. So really strongly clear from the survey findings. And women were more likely to report a long-term mental health condition. Over 4 in 10 bisexual women reported this. We also see the rates of mental health conditions doubling, if not tripling, in gay, lesbian women or bisexual women compared to heterosexual women. And 16% of gay, lesbian women and 31% of bisexual women reported feelings of isolation compared to 7% of heterosexual women. So we can really see the gap both in physical and mental health care. We also see that we've got lower rates of cervical screening, and it's really difficult, as you know, for non-binary people to access cervical screening if they're not on the list. And we also know that we've got more to do in terms of our training for our staff to better understand the needs of LGBT women and some of the challenges that trans women particularly have in navigating primary care, whether that's changing their name, changing their gender, changing their NHS number as well. And that is in part training, but also making sure we can get our IT systems in the right place to support people to have a service and the care that they recognise and that they absolutely should do. The other thing that I just wanted to flag was the support that we need to really keep building on, and we're working with Michael and the LGBT Health Team here on supporting general practice teams with hormone prescribing while on the waiting list for the gender identity services. So some really key elements there. We're working with partners to develop that learning because I think that is absolutely key. So the training that we have for primary care staff on LGBT health inequalities and how to address them, and we share those, and we will keep sharing those, and we've got real commitment to creating a more inclusive primary care environment, because if people can come forward for their primary health care, we know that that will have an impact on their physical and mental health needs as well. So look, I'm definitely here to to listen and to hear and very much factor in what you think the top priorities are for us in primary care to make sure that we move from invisible to very much visible, very much recognise and really start to address some of the really toxic health inequalities that we cannot tolerate.
Okay, thank you very much. I think I'm delighted to see that Dr. Catherine Meads is in the audience and has given this question, because for years she has been a lone voice. For over 25 years she's been a lone voice, trying to make the case for the collection of data, and secondly for the training of staff to make sure that they are actively going out and looking for LGBT women to be identified within services. Interesting point she's put up now. Nobody's collecting data about LGBT people and COVID, just not there, and nobody expects it to come out anytime soon. So to both of you, on the basis of taking a sort of system-wide perspective and at the level of interaction with individual people in the surgery, what is it that you think needs to be done to bring about a change in attitude in terms of identifying and working with the patients that come forward to you? Sue, do you want to go first?
I go forward, yeah, first. Yeah, that's a great question, and I think that it absolutely needs system-wide support. So I think that there are certain building blocks that need to be put in place, and I think it's absolutely, leadership is really, really key. So it has to be a topic, an area that's held as important right from the top, so within NHS, within PHE, within Department of Health, and then cascading down through all the systems more locally so that it reaches the frontline staff. So I think leadership is really, really key. I think the second thing that you've alluded to is data. And it's not enough just to collect data. It's about using data and training people to collect it effectively so that actually it translates directly into determining need. But it's also not just data, it's about hearing people's voices. So making an effort to actually listen to people's experiences and what those experiences are, but not just be appalled, actually translate those voices into direct interventions that change. I think that
okay, but for 15 years the organizations in our community have been telling you the experiences of lesbian women coming forward for cervical screening. experiences which are appalling. We've got it there, but how do we get that into whatever it is that brings about change within the NHS?
Yeah, and you know, I think unfortunately it's more than a training. I think training is utterly important. So it's not really just it's about a cultural shift as well as a training shift. So I think that we need to be able to take it back to basics, make sure that we think about the issues right through the whole pathway of care. So I think training all our people on the front line, but also training people within the whole wider system. So in terms of, you know, reception staff, management staff, and so forth, in understanding their some of the issues that are being experienced and address them directly. And I hear what you're saying totally, that this is something that it has been said over many years and hasn't changed. I would really hope to get something much more instrumentally in the strategies going forward, and I think that would be an important part, a really a driver to actually ensure that there's some accountability for making things different and making sure we measure to demonstrate that there is palpable change. And we'll only see when women take up those services like cervical screening more, will be the sort of proof of the pudding, I guess.
If I can come to Nikki, I mean, I hear that. I see the frontline staff who've done the Rainbow Badge initiative because nothing's been happening at all. And what we're getting in the NHS is individual committed staff who can see that the services that they are providing are not appropriate to anybody. But it's very much left to them to get on with it. We've still got policy documents, we've still got strategies that come out with gaping holes in them. So how do we get this through to the decision makers and the people who then take those decisions, work them into the data sets, work them into the training programs, and actually make a consistent difference, so that it's not up to every individual patient to walk into a service and figure out whether it's safe?
So I think you make a really fair challenge. I find far too often that people are having to fight an individual fight. So I think we need to do two things. One is make this the business of everybody in the NHS in a way that we haven't so far, but very much make this the business of people who are making decisions. So within the primary care space, I can commit really clearly to making this our priority as we move forward out of the pandemic, thinking about the impact of the pandemic on the lived experiences of LGBT women, but also more broadly, because I think we haven't got enough of a focus, and that's rightly what we should be doing. So how do we prioritise the training that Sue mentions and that we know is out there? How do we prioritise taking a more inclusive approach, and how do we embed data into what we do? So I'm really happy to take that as a kind of key priority as we move forward, because we rightly do need to.
Okay. There was a time when we wouldn't, in a session like this, have been discussing gynecology, contraception, postnatal stuff. We are now. Things have changed in our community. But I want to ask you how you think all of the women's LGBT women's reproductive health services can be improved. Because again, I hear anecdotally that it is very, very hit and miss. And that's right along the care pathway. Sue, do you want to go first?
Yeah, so I guess putting a question back to you about the pathway into fertility, or the pathway into contraception, or a bit of everything.
Could be anything, actually.
Anything. Yeah, I mean, I think it goes back to the same thing. It's about inclusive services. So I don't think that it's about making. I think it's about recognizing the scope of need across the board, and recognizing that being non-inclusive is being exclusive. And so the fact that if we were able to hear, I guess, and to listen to what was being asked for, rather than making preconceived judgments about what is and isn't needed. And I think part of that is hearing the story about what is needed. You know, I'm not, but I think that it isn't difficult for individual practitioners to put someone in front of you, as you do, and ask them what they need, and provide it. So I think the difficulty is with the asking and with making it inclusive. However, the kind of attitude pervades from above. So I think that on one level, it's about just simple, basic communication skills and being able to deliver care according to making patients the centre of the care that you're delivering. So it's about providing what's being asked for. But in terms of actually the structures, it's something that comes very much further from above to actually make those things more possible. And going back again to not just relying on individual practitioners to provide good care, but actually provide a system that is just normalising good inclusive care.
Okay. Nikki.
Thank you. What would be great, maybe in the chat bar, if that's possible, or even as in the Q&A, we know that we've got some really good flagship examples of what works, particularly those who've had or practices that have, if I look at the primary care end of the scale, that have gone through the training that I've described. But if you have got examples of good practice that we can build on and amplify, I'd be really keen to hear those, so that we can make sure that we are sharing those with other practices, and really moving to a place where this is the norm rather than an exception. So if you could do that, I'll make sure that I collect those. Thank you.
Well, we know that health inequalities is something that is supposed to move the dial in the NHS. So, and we also know that in our community, we do have worse health outcomes across a whole range of indicators, from mental health to cancer to drug and alcohol, and also to teenage pregnancy. So we've got that data there. What do we do with that to make that hit the dials of the hit the inboxes of the people who really do care about that, even if they don't care about us? And from talking to your colleagues, you know, you tell us some of the I can tell you loads of good examples of stuff in individual trusts, and I can tell you about it about good partnership working with community organisations. But I would like to know from you what you know from the people that you talk to and your colleagues about services. What are the ingredients in services that make them good and make them address those health inequalities? Sue.
So I think you make a rightful challenge, because I think that we talk the talk a lot about inequalities, and we don't necessarily walk the walk in terms of impact. And you're right that the data is out there. And I suppose what I would say is, yes, you know, listen to things that have worked. But also I think that there is a real drive to say that, and this I think sort of stretches across all the really, really marked inequalities that we see, that actually if we focus on those groups in whom the outcomes are poorest and get it right for them, then the rest will follow. And I think what's always happened in healthcare provision is that we focus on the 80 to 90%, and we think, oh, if we get it right for them, it's good enough. But I think we need to shift the narrative to say, actually, we need to focus on these groups who are experiencing the poorest outcome and make sure that we get it right for those people first and foremost. So I think really flipping the narrative towards actually that as the starting point. So that isn't quite answering your question, because obviously, you know, what works, you know, and again, you know, we need to listen to what works and what needs to happen. There isn't a magic bullet, but I think by prioritising the groups in terms of what we actually take forward is a really sort of key starting point.
Okay, Nikki?
Should we just talk a little bit about pride in practice, because I think that's probably what I describe as gold standard from my perspective, and particularly from primary care general practice. So for those who aren't aware, this is part of the LGBT Foundation, so Quality Assurance and Social Prescribing Programme. So as we've tried to develop the assets that we can offer people in primary care, we've built up quite a strong social prescribing programme, but this is broader than that. It's about strengthening and developing primary care service relationships with their LGBT patients. And it's about linking primary care services into the wider community assets. And somebody asked a question about, you know, that social part of care, and this very much does this. So it's a co-produced scheme, which includes not just training, but a set of dedicated sort of support needs, support for primary care services, credentialing, very much demonstrating commitment to a fully inclusive and patient-centred service. And, you know, I hear the difference, the experience of individuals who are who receive care as part of a practice that is in a pride in practice scheme. There is a strong link to community leader volunteers who provide insight and lived experience to ensure patient voice is very much part of that practice's development journey. There's support that promotes signposting and social prescribing, so linking into the community, connecting with community assets to facilitate a more holistic approach to care. Obviously, there's the training that I mentioned around LGBT inclusion, so it's appropriate services. Somebody was mentioning in the chat bar around confidence building with staff around terminology and appropriate language, myth busting, trans status monitoring, a compendium of sort of advice as well, and then some of the other things that you'll have seen, posters, rainbow lanyards, etc. Really key as part of a wider holistic offer. And so that's been going on for a few years now. We're in, you know, well into the hundreds of services that that are part of the scheme, and we need to keep amplifying that and keep rolling that out, because it is very much the right step that not just ensures good practice, that complies with the Equality Act as well. So that's for me, Baroness Barker, is what good practice looks like, and I want to see more of that.
Yeah, but Nikki, can I ask you? I mean, it may be, you know, grossly unfair, but, you know, most of us have a sort of view of GPs, you know, fighting off people like ninjas, you know, who want to, you know, who want them to do stuff. What was it that got this initiative over the line, other than the LGBT Foundation hammering away for years and years and years and churning it? But what got this over the line with a group of GPs? When we've got data on cancer outcomes, we've got data on so much that doesn't get the traction. What is it?
So, well, I think it's two things. I think it was a real drive for the policymakers who were part of that programme, and I was not, but I've seen the effects that it's had. So a really relentless drive, and it does need the championing of some practices or attendees, members of practices that genuinely get it, so they can then share within their communities as well. And I think the difference that we have now that I want to be able to build on, that I will build on, is in 2016 we didn't have primary care networks, which is groups of practices working together to deliver care differently. I think now we are in that position where we've got practices who are working together, and so we're not relying on small practices in the same way that you described, sort of ninja fighting off a range of initiatives, but saying actually at a primary care network level, which is about 30 to 50,000 patients, this is one of the things that actually has to be top of your agenda. That, you know, and that shift is going to give us a chance to sort of think differently about how we offer care to people, and we need to build that in.
Okay. One person asked a question which I think is quite an interesting one. It was really about the role of commissioning. I mean, to what extent does commissioning affect what you do? How big an impact does it have? And who are the people within the NHS who have an impact on commissioning? Sue, do you want to crack that?
Yeah, so I think that's a really good question, and I think that for sexual health, I mean, it's complicated because it's part commissioned by local authorities and it's part commissioned by NHS, and so that introduces another complexity. But I think, one really important thing might be to think about how to build inequalities monitoring within contracts. So, you can essentially contract a service in whatever way you choose. You can determine what the specification of the service is, and then you can ask your provider to deliver to the contract. So I think that actually it would be, so there are national specifications which aren't requirements, but they are sort of guidance for local commissioners. So one thing is to think about how can we put monitoring into the national spec, how can we get that into local specifications, and then how can we ensure that providers maybe have the right training, collect the right data, and demonstrate that they have a reduction in inequality. So I think that that might be a really good lever. And another lever, I did want to just pick up on one of the things that Nikki said, because I think that absolutely rightly, primary care networks are a bit of a game changer potentially. And certainly a lot in this field of women's health, some new primary care network models are emerging, lots in fact, which are really trying to get closer to the populations they serve. So serving a population footprint rather than just people who walk through the door. And I think, again, that's an opportunity to say who are the people that we need to serve in this local population, and who do we need to reach better than we already do. And actually that localism enables the examination of inequalities to happen in a more coherent way, and for local solutions to be developed that address the groups that are most disadvantaged. So I think it is actually coming in at all those levels. So it's not just the providers, it's the commissioners and the national policy makers who all have a place to kind of act in this and a part to play.
Okay, and I'm going to take that as an opportunity to say to everybody, the census is coming up. Register yourself in the census, because if you don't register in the census, then you don't get counted. Then these people get left off the hook because they get to ignore us. So make sure that you do that if you live in Britain. Nikki, commissioning.
Yes, I was just going to say on the census, I was particularly struck by the private link as well for people to register if they need to. So really strongly support that. I mean, Sue's described exactly the right commissioning cycle. I do think it does come back to data though, and we need that data to drive what we do, our intentions. So part of that is a census, but also asking, in every bit of the system that you might be working in, where is the data? Is it inclusive? Are we looking at the breadth of the population in the way that we should be? And how is it driving what we do? And how do we use, it might be staff forums or networks, it might be patient or population staff forums or networks, to really then take that data and bring it to life and help us commission services in the way that they should be, truly kind of strategically and population facing.
Okay. One of my themes for this International Women's Day is about diversity and the growing diversity of women in general and the diversity of our community as well. We now range from women who are aging well without children, through to people who are having children, raising children, through to people who are trying to start families. We are Black, we are disabled, we come from all sorts of different financial backgrounds. But the key thing that we have in common, and the thing that always seems to get shoved out of the way, is the fact that when we sit down with health professionals, the part of our LGBT identity is the one that disappears behind all of the rest. And I have a degree of sympathy only a degree of sympathy, particularly with general practitioners, because I think that most general practitioners, when somebody sits down, I'm a lesbian, their head explodes. They really don't know none of the things that they got taught, work. And the key thing that I want to ask you is, I rather think that if we wait for the Royal Colleges and the deaneries and all the people who are in charge of NHS training, we're gonna wait forever. We really are. So what is it that those of us and particularly people like Catherine, who are working away within the NHS, can do to bring our force together, and rather than being a collection of being all individuals who are ignored, how do we get some collective weight behind those people who are trying to bring about progress and do the right thing? Sue.
Yeah, I mean, that is such an interesting point, and I think that the key is in the diversity, isn't it? Because I think that diversity is obviously a kind of massive celebration of who we are in all our kind of diverse needs and identities. And I think that every person has a slightly different need and a different identity. And so I suppose that what strikes me as you say that is about really trying to move the agenda more about broad inclusion and broad kind of, so actually obviously some identity is a really important thing to preserve, but also around that to accept that I think it really goes back to my sort of original point about kind of broadening out the question and the inclusivity of that interface between a practitioner and a person sitting in front of you. Like you say, women have needs from, from puberty right through as they age well, and a lot of those needs will cross over and a lot of them will be different. And it is really about trying to, I think the key is about it in the acknowledgement of the diversity and really joining within the agenda of intersectionalities, I guess, and sort of really trying to understand how those needs can band together and actually get people to listen.
Thank you. Nikki?
I would like help from the audience, actually. I want to make sure that we do this right at each level of the system, and we've got a way to go. We can do things certainly from my end that moves faster than a curriculum moves, and that is, through the work that we already do with practices. So I will take that way and build with our health team and others a programme of outreach into primary care to make sure that we are supporting that transition from kind of thinking about one part of a person to a person with all of their parts. But again, please do tell us what other things we need to do that you've seen that we can take away and learn from, and that could be from a policy space or a contractual space or a good practice space. I think this is a genuine offer from or ask or plea from me, which is let me take away what is needed so that we can really focus on it in primary care and come back to this event or another one similar and show you the progress that we can make when we learn from the wider community.
Okay. Sue, Nikki, thank you very much for being game, for being up for what I hope you thought was not a dull session. The biggest sin in the world is being dull on Zoom. I will not do it. And thank you very much for taking the questions in the spirit that they were meant. Gonna move on to our next. Nikki, I know your time is precious and you have to go, but thank you so much for being with us and being part of it. We're going to move on to our next two speakers. Our first speaker is Dr. Kate Nambiar. And Kate is a sexual health and gender specialist doctor who works in Brighton, and she works at one of the London GICs. I'm going to chair this by saying we know that there is a court case going on with the Tavistock at the moment, so we are not going to talk about that at all. Quite happy to talk about broader issues about GICs and access and so on. But really what I would like us to think about is the trans throat cough. I remember when the Women and Equalities Committee a few years ago did one of their first reports into trans issues, and I remember a trans person talking about the trans cough and how basically every time she went to see her GP, the answer to everything was for her to be referred to the gender identity clinic. So let's talk a lot, I hope, about primary care. Kate, you are very welcome. Over to you.
Thank you so much. I just wanted to start by recalling an experience that I had. It was my first experience of transphobia as a young trans woman. I just started my transition. I remember coming home in the evening, it wasn't particularly late, and a car pulled up alongside, and there were about three or four men inside, and I could hear them laughing. I could hear them, they shouted insults at me. They were trying to bait me into a response. I kept walking. I tried to ignore them. And they eventually got bored and they drove off. But I was terrified. They could have got out of the car. They could have chased me down the street. They could have attacked me. I didn't know if I could run away fast enough. And I know that many of you listening here now know exactly what that feels like. And you have all seen the tragic story in the news about Sarah Everard, and you'll know that fear, that's real, that fear, and it's not an overreaction. It's not irrational. That is real. But transphobia can take a lot of different manifestations. It's not just about people being violent or shouting insults. It can be really insidious. It can be the people who want to tell us as trans women that we're not women. It can be down to wanting to keep us from being able to access the care that we need. It could be putting blocks in the way for that. It could be trying to erode the rights and privileges and the things that we fought hard for over the years. And I just see that getting worse in the society that we live in. So you're probably asking, well, why on earth am I talking about that? What has that got to do with healthcare and healthcare inequalities? Well, it's a basic sort of public health 101 that where a population is marginalized, where a population is discriminated against, disenfranchised, their ill health will flourish. And we see that throughout the world. We see that particularly with trans women throughout the world. And my first, my training was as a sexual health and HIV clinician. So I'm just going to use HIV as an example of that, because it is relatively well studied throughout the world. And some people have heard me speak or other clinicians speak about the disproportionate burden that trans women carry in regard to HIV prevalence. One meta-analysis showed that 19% prevalence in trans women worldwide, and that's huge. But that figure, it's been spoken about a lot, hides the fact that there's this enormous variation in HIV prevalence. Some countries have, India, for example, has an HIV prevalence of trans women around about 45%, so nearly half of them. And what is it that's causing that huge variation? Why is it that somewhere like Australia has much lower HIV prevalence? Well, this generally comes down to marginalisation. It comes down to discrimination, as I said. It comes down to denial of people's rights to work. People sometimes being trafficked, people being forced into the shadow economy, into sex work, where they have no other option, they have no other choice, they can work in a safe way. People not being able to access free healthcare, free HIV testing, and trans healthcare. So that leads me to think, well, what about the UK? Where are we in all of this? And we do have some data to show for that. And we have data because we have been able to monitor gender identity within the people who are diagnosed as being HIV positive within the UK. We've been doing that for quite some time and doing that very successfully. It's due to work that a number of people, myself included, have been campaigning for. And we can see that the prevalence of HIV in trans people within the UK is vastly lower, like orders of magnitude lower. Talk about 0.05% of trans people living with HIV here in the UK. And so, what is the difference? Why is that? Why is that the case? Well, we have much less in the way of discrimination. We have a Gender Recognition Act that enshrines the legal recognition of trans people here within the UK. We have an Equality Act that protects trans people in the workplace. We have an NHS that provides free HIV testing, free trans healthcare, with all of the caveats that will come along with it, which I'll talk about. And so, in some respects, you could see this as a bit of a success story, perhaps. So does that mean we can just sit on our laurels and just say, well, we've got it all right, we're much better than everybody else? Well, no, of course not. One of the things that worries me intensely is that we're looking at the potential for some of those rights to be rolled back, or for people to be challenging that, and that worries me intensely, because those impacts on healthcare may well be affected by that. It makes that concern for us as trans people even more acute in terms of how that affects the lives that we live on a daily basis in regard to transphobia and the sort of the general climate around us. And so, going back to HIV, I thought that, well, I've worked in HIV for a long time, and I've seen how our specialty has been built up and it's responded to the needs of the pandemic. HIV positive people right at the start of the pandemic were in many cases demonized and vilified, and people didn't want to engage with them. And the stigma of HIV held people back from accessing good quality care. People didn't want to go and get tested because they were worried about the impact of this. But the stigma of being trans, that's something that still lives with us. It's something that lived with me for many years. I was so ashamed of my transness that I wouldn't even want to talk about it. It negatively impacts people's mental health. And there's study after study that has demonstrated this, that there's a higher prevalence of depression, anxiety, substance misuse, suicidality within trans people. And where people are able to find people are able to transition, people are able to break beyond that discrimination, we can see a lowering of those. So I think that if we really want to be serious about how to improve trans healthcare, we need to be serious about how we address that systemic discrimination within society.
Kate, can you just move it along a little bit, do you think?
Yeah.
We've
Sure.
got a short time. Yeah.
A couple more things. The second thing I think really is around training in services and investment in the services and the training. We've talked again about HIV care. It expanded to meet the needs of the pandemic. And I think that we need to be thinking about how we do that within trans healthcare. When I was going through my transition, people used to talk about how we needed to educate our GPs. Why is it decades later we're still having that same discussion? Why is it that when we go to our GP, just like Baroness Barker was saying earlier, we are in a situation where people are being, can go along with a simple condition, but it can feel conflated with people's trans identities. Someone breaks their arm, it isn't necessarily because their hormones have made their bones brittle and broken their arm. It's probably because they've fallen over and broken their arm. Why is it that when I transitioned in the 90s, the waiting lists for GICs were enormous then? Why is it we're still having the same conversations 13,500 people in 2019 were waiting to be seen for first appointment at a GIC. This isn't something which we should be talking about now. This is something which we've been talking about for years and years and years. The last thing,
very quickly,
is if we're going to make a difference, we really have to listen to our community, listen to the activists, listen to the people who are telling us, the trans community ourselves are the people who are going to be able to guide us in the way that we're going to be able to make a difference. Just like with HIV, we listened to the activists, we were embedded within that as clinicians, and it's made a difference. So I think that those are the things that I would say are going to make the biggest difference in how we improve the lives of trans people in terms of our healthcare. Sorry.
No, it's important, and I spend a lot of time knocking around with my mate Norman Fowler, and when It's a Sin comes up, when the Lord Speaker comes along and says, "Have you seen It's a Sin yet?" A lot of lessons come flooding back, and now is a very good time to think that we are, in terms of the law, in terms of our NHS provision, we are perhaps best placed in the world to be world leading in terms of services, and we have to question why that is and why it's not. Okay, thank you very much indeed. Nancy Kelley. Nancy is Chief Executive of Stonewall. I've probably seen more of Nancy this week than I've seen of my nearest and dearest.
We're new best friends, you and me.
We are indeed. Nancy, who is leading Stonewall expertly through a period of unprecedented turbulence and attack. And Nancy, who deserves all our support for doing that. You go talk about mental health, aren't you? And other stuff around that.
I am, and I'll try and be brief. And as Liz knows, I'm a working class northerner, so I talk quick, so that will help. Firstly, I just wanted to say something about our vision at Stonewall. So because it's really relevant to these questions that we've all been talking to today. And at Stonewall, we imagine a world where LGBTQ people everywhere are free to be themselves, and a world in which we can live our lives to the full. And I think that vision really matters when we talk about lesbian, bi and trans women's health. So this is a situation where there are deep and persistent health inequalities that everybody here has alluded to. And we've kind of become used to that, but we shouldn't be used to it. We shouldn't accept those profound and persistent health inequalities. We should imagine that world where they don't exist and be moving actively towards them. I'm really conscious the theme of this year's LGBT Women's Health Week is kind of talking about these more taboo topics. So I'm going to touch as quickly as I can around some issues to do with mental health, and then a little bit of sexual reproductive health and inclusion. And I'll try and sort of respond to some of the questions that have come up in the chat as I go, if I can. I think the starting point, though, as everybody's acknowledged, is that LGBT women experience significant health inequalities across the lifespan, starting from a really young age. So, high rates of poor physical and mental health compared to cis and straight women, higher rates of obesity, cardiovascular disease, self-harm, mental health, you name it. And I think pausing and picking up something that other speakers have pointed out, we're a really super diverse community. LGBT women are not one thing. We're ethnically diverse. We are diverse in terms of being abled and disabled. We're diverse in terms of our socioeconomic status, our migration status, etc. The driver of these poor health outcomes isn't some kind of inherent characteristic that we all share. It's the experience of living lives deeply and profoundly affected, as Kate was saying, by stigma, by discrimination and abuse. So to put it really bluntly, it's homophobia, biphobia and transphobia that's harming our lifelong mental health and health impacts. And so that's not the world we should imagine for lesbian, bi and trans women, and it's certainly not the world we deserve. So I think that's the kind of starting point for me. Just a couple of things really on that mental health picture. So both in the UK and internationally, we know that there's much higher prevalence of mental health problems of all kinds amongst lesbian, bi and trans women when you compare them to cis and straight people. And as I was pointing to, actually there's loads of evidence that proves that's not because of anything other than stigma, discrimination, abuse. That's what causes that differential. So all of these kind of research around minority stress, so repeat exposure to discrimination or the anticipation of discrimination or rejection or homophobia, biphobia, transphobia is what is driving that. And when you have people who experience intersecting forms of oppression, so LGBT women of colour, disabled LGBT women, you get that compounding even further. And obviously Kate's spoken really passionately about the compounding effects experienced by trans women and in terms of their mental health. Just a couple of numbers, so kind of NHS data, you've got 27% of lesbians and 42% of bi women reporting a long-term mental health condition. So I think one of the questions was about bi women's mental health. And I think it's a really interesting question. One of the theories about why bi women and trans women actually experience, in a lot of the studies appear to experience worse mental health outcomes than lesbian women is because of the nature of biphobia, which bisexual women experience both inside our LGBT community and in the straight and cis world. So I think there's a lot to unpack there, but I think that sort of minority stress piece looks a bit different when there are no safe spaces for you, really. And prevalence of self-harm is also really high amongst LGBT women. And we know that there are particular issues, as Kate was talking about trans women even accessing support services around their mental health. I always want to shout out on mental health to teenagers. So going back to this issue about these are lifelong health inequalities caused by stigma and discrimination. The data we've got from the Child and Adolescent Mental Health Survey shows us that the prevalence of common mental disorders, so it's a diagnostic standard, is twice as high for LGBT teenagers as is for cis and straight peers. It's extraordinary. No, nobody should have an excuse not to know that and be doing something about it. So what does change that picture? I think for me, there's something about how do we change this environment? So if this is about stigma and discrimination, this is about LGBTQ inclusive education from primary school to professional training and CPD for nurses and doctors and healthcare workers, right? It's about a step change in political leadership, about rights, as Kate was pointing to, a step change in the language that political, institutional, media leaders use to talk about us. It's also about these big change programs. So the fantastic Pride in Practice has been talked about, and Pride in Care that's run by Opening Doors, the Rainbow Badge Scheme that Stonewall and LGBT Foundation and Consortium and others are now privileged to pilot a second phase of. Also programs like Stonewall's Diversity Champion Programme that is about institutional change in attitudes and inclusivity. And it's about investment in voluntary and community sector initiatives, including those that target prejudice. It's about investment in care. Mental health care is just so grotesquely underfunded, and better care for the women and girls that are suffering. So investment in LGBT women's specific inclusive health services and in specialist services. I'm conscious we've talked quite a bit about sexual health, so I'll talk about reproductive health briefly and kind of carry through some of those themes. So one of the kind of many inequalities that we've come to accept as a society is a structural inequality in access to reproductive health care for women in lesbian relationships, right? So where straight couples or couples in heterosexual relationships are expected to try conceiving at home as the gateway for IVF, for women in relationships with other women, you have to go through multiple rounds of IUI, of intrauterine insemination, which is not in most places available on the NHS. And what that equates to is, if you're very lucky, 10 grand. And if you're very unlucky, a lot more than that. It's a lot of money. It is a barrier that for many women is simply insurmountable. And if you can't meet that barrier, you can't access free NHS care. And I think for me, what I find really personally shocking is when I first considered starting a family many years ago, I'm an adopter and a very happily so. I remember going to a fertility clinic when we were exploring kind of our options and watching a working class lesbian couple break down in the waiting room, having just realised that fact. And the fact that all of these years later, we still have this just basic structural inequality around family formation, it's just astounding to me. If you're through that hoop, you've got a postcode lottery. Not all CCGs include lesbian and bi women in terms of their guidance around reproductive health care. Not all CCGs will pay for sperm, which is a pretty, whoever knew that this would be such an expensive hobby, but indeed it's an expensive commodity. So there are all of these structural barriers in terms of access to reproductive health care that still exist. For all LGBT women and for non-binary people and trans men going through reproductive health care, when we access those services, we meet pretty much a wall of homophobia and transphobia and heteronormativity. So harmful assumptions about our families, forms that don't reflect our families, birth records in the UK still assume that families are all built around cis and straight couples. So I think about that, and I think about how many times I've had to cross out the lines on basic forms to make it accurately reflect who I am and who my children are. And I think about the fact that all around the country, LGBT women are doing that right now. And I think there's also some really interesting things about the very painful knock-on effects of all of that homophobia, biphobia, transphobia. So there's a study by a researcher called Malmquist and a whole team that found that pregnant and lesbian and bi women, as well as non-binary people and trans men, are much more scared about giving birth because of their experience of lack of trust in their healthcare providers. So kind of what things need to change? Well, policy change about access to reproductive health care, policy change on identity, whether it's NHS records, basic forms, birth certificates, so our families are recognised as they are, investment in training, investment in institutional change programmes like Pride in Practice, like Rainbow Badge, like DC, and building those really close partnerships that Kate's pointing to with the community sector, with the voluntary sector, with activists. So we should be able to expect that we would be welcomed kind of warmly wherever we go in this system, and especially when we're doing something as sensitive as starting a family. I just want to make a few general points to close around like access to healthcare generally for LGBT women. So National LGBT Partnership research, what you see is that one of the biggest single complaints from lesbian and bi women is that all of the frontline healthcare professionals assume straightness, and everybody's talked about that, but it's just so important. I have never gone to a healthcare provider where I haven't had to like come out like 27 times, and almost at every time, kind of, that's my wife. What do you mean your wife? Is this your husband's name? Why is your husband called Jen? My husband isn't called Jen. I'm a lesbian, and then you sort of start shouting, I'm a lesbian, tick the lesbian box kind of thing. So that causes just immense breakdown of trust in healthcare providers. We know that means a lot of people just don't tell their healthcare providers then. So kind of a little over a quarter of lesbians and less than 10% of bi women even attempt to have that conversation. And those experiences are much more significant for Black LGBT women, Asian LGBT women, other LGBT women of colour, who are more likely to be assumed to be straight and are more likely to be assumed to be cis. And so I think all of that sort of basic access issue demonstrates the ways in which we're kind of discouraged from attempting to access healthcare, from being able to access healthcare that meets our needs, and that contributes to those stark inequalities. So I think for me, there's a real call to action about a step change in the inclusivity of mainstream services, about better funding for specialist services, including those that are led by our sector. And we know that goes from the top to the bottom of the NHS. This needs to be hardwired into commissioning strategies. This needs to be hardwired into people strategies, as Liz was saying. Staff should be trained from initial training through CPD and throughout. Sexual orientation monitoring and gender identity monitoring is essential. People talk about it as if it's kind of absolute rocket science. It's not rocket science. It's fairly straightforward. There are barriers to implementation, but it's not complicated. And I think there's also softer things like material that's relevant to us in our lives and images that are relevant to us in our lives being available in healthcare settings so that we know that we're welcome and that we're held in mind. And I think focusing on thinking about where we need and deserve specialist provision. So I think particularly around mental health and areas like mental health and reproductive healthcare services, both in and outside of the NHS, where we need something distinctive to be supplied in order for us to have better health outcomes. It's a bit of a laundry list, but I think we need all of that and more to build that world where lesbian, bi and trans women are able to live our fullest lives, are able to live the lives we deserve.
Thank you very much. I'll let you both go on a bit longer because you picked up quite a lot of the questions that that people have asked. But let's go on about chasing rainbows. We know that dotted across the NHS, there are people who do want to make a difference. And the question, I think, is how do the rest of us manage to find them and equip them with the tools for those of them working on the inside to say, well, this is the population we are supposed to be meeting. We're not. This is how people are telling us that we should do it. How do we do that? Kate.
It's a really good question, because even now I come across times where people are doing, setting up a service or something's happening in another part of the country, and I think, oh, I didn't know that was happening. We don't have any sort of established kind of network or even any kind of forum where we can share best practice, and so it often comes down to individuals within whether they be clinicians, policymakers, people from CCGs or whatever, coming up with an idea and putting it out there, and then seeing whether this works. And it doesn't feel like that's, particularly in the trans healthcare, doesn't feel like that's a particularly efficient way of doing things. So I'd love to see some sort of network where we can share these ideas. A forum like this is great as well, because that brings together people. Conferences, discussions, those kind of things help to bring together people and to share good ideas. But yeah, it's a shame when there's great examples of local good practice that don't get shared more widely.
My understanding is that just in the world of sex and reproductive health, things like access to contraception and abortion and so on, there is a massive move towards telemedicine, digitization, that part of which has been accelerated by the pandemic. Now, may not work for absolutely everybody, but for lots and lots of people, that is going to make a better service. It seems to me that if we are in a time of unprecedented change, and with the use of technology, it being much easier to do specialist collaboration and to get people together, how do we seize the opportunity of that afforded to that, to get those people who may have been isolated in the NHS and build a momentum for change? Nancy, do you want to think about that?
I'll have a go. I think you're right that the kind of some of the pandemic response gives us an opportunity to do things differently, and I think that kind of cuts both ways. So there's a relaxation about care for termination of pregnancy that's really important for lesbian and bi women, for non-binary people, for trans people that would feel really worried about maybe going in for abortion related care in person. And so kind of the idea of, can you extend that sort of provision? But I also feel really wary about that on the flip side, because I think we shouldn't have to kind of have healthcare at home because we can't trust a frontline practitioner to not treat us shitty, right? So I think it kind of cuts both ways. I think there's huge potential, but it shouldn't be a kind of excuse for in-person services not being effective. I think that the ability to use kind of networks and telecare and those sorts of things, and also to use digital networks as a way of transferring best practice and creating the kind of knowledge exchange that Kate's pointing to, I think is really important. I also think that kind of the NHS as a whole and government and DHSE in particular has got a really important role to play, because sharing flagship examples of promising practice through communications channels that meet large swathes of the healthcare setting is how good practice in lots of different areas is developed. So there's something about being proud at a national level of all of this good practice and not just relying on local practitioners to network with each other that I think is also really missing from the picture here.
Yeah, and I've always I've had a long time bee in my bonnet about the big management and accountancy companies who provide a lot of the sort of management and training stuff into the NHS, and I'm pretty sure that every one of them has got an LGBT network, and every one of them turns up on Pride. But I really wonder how much that works its way through into their daily work. Okay, lots of questions around lots of questions and people raising issues about various stages, understanding the diversity of LGBT women's lives and family lives, and how we can take the interest that there is around that and put people in touch, particularly in building bridges between people who are in research and academia and practice. That seems to me to be a very important aspect of this. Kate, do you want to suggest how we might do that?
Yeah, I completely agree that there's some amazing work that's been done within academia, but that doesn't get filtered through to or translated into good practice. And I'm not sure I have a great response for that. I'd love to hear if anybody in the audience has some suggestions for how we can translate that research. I do worry in some cases that the research work that's being done is sort of it stays very blue sky. It doesn't get filtered down into this. This is something which we've seen in our study is going to make a difference. Let's try and put it into practice. And to a certain extent, we need to be better at being able to communicate the output of that research.
Nancy?
I think there's a real potential to build on some of the successes of some parts of the What Works network. So kind of there is a whole infrastructure that's building up over the last 10 years in the UK about evidence transfer. So how do you take the academic evidence, distill what makes a difference and get it to practitioners? And I think thinking about how we can inject a focus on LGBT women's health into some of the work of the various What Works centres is really worthwhile, but that model can work very, very well and does work well. I also think I've always been a fan of critical evidence appraisal training. It's gone out of fashion, but making sure that people who work in health services know how to understand the evidence. So there's both things, isn't there? There's translate the evidence and there's help people evaluate the evidence they're presented with. And I think that would be really helpful as well, because at the minute there's a kind of gap between research that is neither translated nor translatable. And I think you can close that gap from both sides.
Okay. Well, that's interesting. We're coming towards the end. I want to give you both a chance to say International Women's Day. If you could have your sort of top priorities that would make real change to women's healthcare, LGBT women's healthcare, what would it be? Kate?
I would just reiterate that last point that I made. Listen to the communities that you are serving. Listen to women, listen to trans women, listen to trans people and non-binary people, because if you want to make a difference, the answers are there in the communities that you serve.
Okay. Nancy?
I'm going to build on what Kate just said on actually one of the questions from in the chat, which is a midwife talking about the transformative experience of working with a trans couple around with a trans person around their health experience. I think it would be amazing if every single health practitioner had a completely normal reaction to meeting an LGBT woman and just enrolling them onto the service. If they just, in a really straightforward way, listened to what we told them about who we were, recorded it, and only asked the questions that they needed to ask about what we just told them. If that initial contact was warm and straightforward across services, the complicated stuff can flow from that. But if the trust is broken from the start, it can't.
Yeah, I mean, I think. I think that I think it was one of the LGBT Foundation documents about women's experiences of cervical screening, and you just know from the moment that question gets asked, that your faith in that person has gone and you just want to get out of there and get it over with, and not have the full conversation with them about your health that you otherwise would do, which is such a great loss. And actually practitioners, I think, would be ashamed if they knew that was happening, because that's not what they train to do. They train to give people really good healthcare, and really stupid things are getting in the way of that. But there you go. It is International Women's Day. We have to thank Dr. Michael Brady and his team, Lizzie Streeter and all the rest of them, who are the real people who really have got behind this and got our busy diaries together and kept us on side until we did this. I think on International Women's Day we can say that Dr. Michael Brady is number one, an honorary girl for the day, and secondly, it's really good to be able to announce that one of the good things that's happened is that Michael's put the funding for Michael's post and his team, which came out of the government's response to the initial LGBT survey, has now been made permanent, and that really is great news. And it means that for the rest of us, we have at least one point of light within the NHS to whom we can turn. I am in no doubt that, wonderful as Michael and his team are, they need our help to take on all these all the rest of the forces of inertia in the NHS. But I am, even more than that, I am convinced of one thing. We live and are defined under different initials, plus non-binary people, plus people who we sometimes leave out of the alphabet soup just because we're so busy trying to get everything in the time. If we are not together, if we do not treat each other with dignity and respect, if we do not understand our differences as well as what we share in common, then we will never get anywhere. And actually there are forces out there in the world at the moment who would like nothing better than to drive a wedge between us, in the hope that one by one we can all be picked off and our rights that we currently enjoy slowly eroded and taken away. So whatever initial you happen to live under, you have a duty to all of the others to ensure that your own health and the health of those people that you love does not suffer in consequence. I would like to thank all of our speakers, in particular Sue, for being so game to take our questions. I hope that it was a productive session. Apart from that, I hope you all went away with something, not just to think about, but you went away with something that you are going to do as a result of all of this. Because dear me, you know, I've got to have some kind of productivity equation. You know, an hour on Zoom has got to be worth something in real life somewhere down the line. But thank you very much. Thank you to our audience for asking questions. We were trying to paraphrase your questions, not to get rid of stuff, but to try and make sure that we got as many points in as possible. Thank you very much. That's more than enough from me, and I now am delighted to hand over to Philippa.
Thank you so much. And I'd like to extend the thanks on behalf of Leigh Day to all of our speakers, to Nancy Kelley, Dr. Kanani, Dr. Sue Mann, Dr. Kate Nambiar and Lizzie Streeter. And it's been an absolute wonderful afternoon. It's been really insightful. I've thoroughly enjoyed it. I feel educated, I feel empowered, I feel shocked all at the same time. And if you have enjoyed this talk, please do check out Leigh Day's others Women Rights in Healthcare events, which can be found on our YouTube. And I believe that this will also be going onto our YouTube at some point. So if you've missed any parts of it and want to rewatch, then you can go online there. And look out for our future events. So I will just leave it there and hope you all have a lovely evening. Thank you so much.